So anyway, it's a beautiful weather, beautiful city, and I'm going to talk about the many inotropes and what to choose when. The simple question is, if you look on the evidence, there's not much evidence, and we can say that's the end of my talk. But let's see, we make a more logical approach. I had no conflict of interest, although I can definitely declare I didn't vote for Brexit. Neither my city, this is my city of Cambridge, where the Cambridge University, and this is my hospital here. Even overall, as a Cambridge, we didn't vote for Brexit either. Coming to the topic, so yes, I agree with Stefan, and there are so many topics, there are so many drugs, wage-active drugs. I will prefer the term wage-active medications drugs rather than inotropes, but yes, there are, which are commonly used there on this side, and then less commonly used in the NICU, but they're pretty good drugs actually. And then the third category is the pulmonary vasodilators, which are not used in inotrope, but they're very wage-active medications, and they do interact with the others one as well. They often are used concomitantly as well. We need to understand how all they work. So when there's so many drugs are there, your baby's blood pressure is absolutely in the boots, and baby's looking pale, we all get confused. Where should I start? There's so many choices are there. We try to find some evidence. Absolutely, there may not be any strong evidence. We get a little more confused and maybe a bit frustrated. And then you go to your boss, and the boss looks at you. I like this drug. So you start the drug, but then you take to the meetings and try to make a guideline. And if I let you read, we should vote on this. Bearing in mind the spirit of the positive work culture, positive team bonding, you should say yes to your colleagues, and you make a guideline, or maybe in a pub with the experts, and finally, yes, finally we have got a guideline. And such guideline was used almost all units across the UK, Europe, and possibly around the world. This is the neonatal guideline which we have followed for a long, long time. More or less, if a child has got hypertension or underperfused or cardiovascular compromise, which term I prefer, we normally give bolus of fluid, 10 mL per kg, 20 mL per kg. They don't respond, we give some dopamine. They don't respond, vitamin. They don't respond, we go some adrenaline, noradrenaline, and it goes on. But I think there's an important question there. What's our main goal with giving these wage-active medications, inotropes? Our goal is to improve the tissue perfusion, improve the end organ perfusion so that those tissues can get enough oxygen in the blood flow there. But the approach what we followed with the unit guidelines, or this guideline published for about 15 years back, is a very pressure-driven approach. And often you ask a junior, say, blood pressure less than that, start something. But where is this number coming from? There is no consensus, there is no evidence for the numbers. This is absolutely pressure driven. We are not talking about the blood flow. We are not talking about the end organ perfusion there. When developing these kind of pressure driven guidelines or pressure driven clinical practice, there is absolutely no consideration of underlying pathophysiology. No consideration for the compensatory mechanisms or cardiac function or the fluid status. We just make our clinical judgment based on some number which we even don't trust. I think, in my opinion, we are in 21st century, and this umbrella approach, I think, forget the gold standard, in my opinion, is not even acceptable in today's DNAs. Maybe let me ask you guys one question. So in your practice, what is your first line of inotrope in treating hypertension or cardiovascular compromise in neonates? Can we swap around, Francesco? Thank you. As expected, and dopamine is about 77%, is around still 75%, vitamin 16%, more or less what we actually know and most of the what surveys shows. Thank you very much for everyone. One more question for you guys. Which of the following statement is or are true? Dopamine is a vasoconstrictor inotrope, increase both cardiac contractility and systemic vascular resistance. Extremely preterm infants have inherent diastolic dysfunction at birth, especially during the transition in the first 48 to 72 hours. High dose of dopamine can increase systemic vascular resistance and also the pulmonary vascular resistance. 50% of the inotropic effect of dopamine is weaned off is by the release of norepinephrine or noradrenaline, what you call it really, from the myocardial synapses, and is weaned off in very soon. Dopamine depresses TSH and T4 in neonates. Yes, please. This is an important question. I'll give another few seconds. That's fantastic. That's really interesting results really. Dopamine is the most commonly used inotrope. 80% of you guys said that's what you use in your practice. But all these statements are true, sadly. So not 50%, 70%. So facts about the dopamine neonates. Dopamine is the most commonly used inotrope, and multiple surveys, include both population-based registry or the country-based surveys, all show that dopamine is about 70–80% is used. Inotropic effect is depend on the your not only dopamine receptors and alpha-1 receptor alpha receptors, but is 50% of the effect come from the release of norepinephrine from the myocardial synapses, and in a extremely preterm infants, very low birth infants, those synapses resources very little. If you start dopamine within 8 to 12 hours, that effect is weaned off. That's why they may lose that effect, inotropic effect. Even the term infants will live on the dopamine for days and weeks time, that effect will be weaned off as well. And those effects are dose dependent, and they are unpredictable, including the side effects. And dopamine is pretty has got a lot of neuroendocrine side effects. That's why we put the hypothyroidism there only. Personally, I don't like dopamine, but personally, if you look on the PIC intensivists, they will say it's a poison rather than an inotrope really. But in neonates still is commonly used. But I think hopefully towards the end of my talk, let's see if you start thinking why I'm using the drug. So let's look on the evidence. Again, I can do my whole talk on the different studies. There are 21 RCTs, but I'll promise there'll be 1 or 2 slides on the evidence, and I'll take the talk in a different way. And most of these trials, up to 121 trials, most are based on the dopamine, versus placebo or versus any of the other inotrope, commonly used inotropes. Only there are 3 trials which are not on dopamine. That's the dobutamine 2 trials and milrinone 1 trial. And there are many, many systemic reviews, at least 6, 7 I know, and then there is many expert articles. We all are neonatologists, and like our ventilation, managing hypertension is bread and butter for everyone. We all are experts. There are many, many expert articles. Dopamine, as we discussed, commonly used, has been used for over 30 years, and there are more than 60 trials published and many animal studies. We know this drug pretty well. And all these trials and studies show it's definitely superior to the dobutamine in the volume in terms of improving the mean blood pressure, if that's your aim. Its efficacy is similar to the epinephrine or hydrocortisone, and if you compare to epinephrine, you give 100 nanogram or 0.1 microgram per kg per minute, that's equivalent to 10 of dopamine. It also decreases the right ventricle or left ventricle cardiac output and increases the SVC flow. On one hand, it makes the number better, but you are decreasing the blood flow. So it's definitely inferior to certain drugs like dobutamine in terms of you're interested in increasing the blood flow to the tissues rather than the number. If you look on the long-term outcomes, absolutely there is no evidence that improves the long-term outcomes and or prevent the death. But if you look on these protocol, all these the studies and RCTs, there's a big problem there. These are different populations, right from the preterms, 24, 5, 6 week, or the term babies. There are different underlying pathophysiologies. There are different indications why did we start, and different numbers, the different entry criteria and the outcome criteria. The more importantly for me, there's a different underlying pathophysiology and stages of the transitional physiology when you use these drugs. Like say Milrinone, people write it off very soon after a single trial for the preterms, but they use in the first 24, 48 hours, where the pulmonary vascular elasticity is dropping and Milrinone is a pulmonary vasodilator. If you use this drug, that will open up the shunt massively, and your PDA will become significant, your hypertension will get worse. So it's important to understand these drugs, how what the underlying pathophysiology is and when you should be using these drugs. So in bottom line is, with all these trials, just to summarize really, there is not enough evidence to recommend one inotrope or another. That's what I said in the beginning. There is not enough evidence even to recommend that we should treat hypertension or with inotropes. However, we know that persistent cardiovascular compromise will kill your baby. Short-term, long-term outcomes are poor. That's why we all worry, and that's why we treat. Now, question really, when there is not strong evidence, we should go from here. Either it can be physician-based or physiology-based. In my opinion, definitely, I would definitely prefer, I'll go for the physiology-based, because that's far more logical and far more basically targeted. And in today's DNA, when talk the ultrasound for the NEC point of view ultrasound, we can understand the cardiovascular physiology on the bedside far better than we did in 10 years back. And those that will keep on improving, I'm just waiting for a day when I get a probe, keep in my pocket, connect to my iPhone, and can do echo. And this is not far. Definitely probes are there. You can connect your tablet and you can do the echoes on the bedside. So we are not far from there. So most of rest of my talk will be more about the physiology and pathophysiology based approach to management of the hemodynamic compromise in neonates, and there are multiple papers are out there, and including the advances management in that one. For this approach, there are 5 essential criteria and 5 essential facts really if you want to use the physiology based approach. First thing, you need to have good understanding of the underlying pathophysiology, about the systemic vascular assistance, pulmonary vascular assistance, about your loading conditions, preload, and your afterload conditions. That's the minimum. You need to have a comprehensive hemodynamic assessment. Where is the problem? And I'll come to in my talk about how to assess and how to change that one. You need to know what you want to achieve. Once you know what your question is, it's much easier to fix the question. Do you want to improve the number? Do you want to reverse the shunting? Or do you want to improve your tissue perfusion? Understanding the effects and the adverse effects of therapy. As my second question showed, all the effects were true about dopamine. There are not many inotropes out there. Yeah, they look many, but there are not many we use. We need to know these drugs right from the mechanism of action to their effects to their interactions with other drugs as well. And they are nasty drugs. They do have adverse effects, and they should be used to the minimum shorter duration of time, and we need to understand the adverse effects very clearly. And lastly, a comprehensive monitoring for the therapeutic endpoints. And that's really important, because we do not want to give any drug, especially the inotropes, for long duration and more than what they required. So let's take a step back why we are treating these babies with the medications. And if you look on the definition of the shock, which is pretty much standard definition, is a shock is a complex clinical syndrome caused by the acute circulatory failure, and it is characterized by the inadequate tissue and organ perfusion. And the reason why we worry about the treating shock, because it can result into cellular dysfunction. It can lead to may lead to cellular death, maybe organ dysfunction, and ultimately death. So they can be multi-organ failure. And just to point really, there's a hypertension is often late sign in the shock. We know that, and the hypertension, we are not waiting for the baby to be hypertensive before we start doing something. If you look at the pathophysiology, there are the maintenance of the adequate tissue perfusion depends primarily on the 3 major factors. one on the cardiac output. That's the key factor. Blood has to go from the heart into the big vessels for the delivery. Second, the integrity and maintenance of the vasomotor tone of local vascular beds in the arteries and arterial, venous and capillary bed. And third one is the ability of the blood to deliver oxygen and nutrient substrates, and also the removal of the metabolic products like lactate and everything. If you look at the cardiac output, and I'm not going to, this is not echo based talk really, briefly there will be some echo. I cannot completely shy away from the echo, but there are only a few slides I'll talk you through. Cardiac output we know is a multiplication of the heart in the stroke volume, and stroke volume is influenced by the preload, afterload and myocardial contractility. There is a pump, it has to be filled and it has to pump, and again certain resistance, very simple. Depends on the underlying disease pathophysiology compromising the cardiovascular system, any of these components can be altered. And once we know which one is altered, it's easy to fix that one. If loading conditions are poor, is a hypovolemia, we can give volume. Same with the vascular resistance, if they're high, we can decrease vascular resistance. Drugs are out there. Just we need to understand what we want to achieve with those drugs. Vasomotor tone of the local vascular beds is more complex, and it depends on the autonomic circulatory, autonomic nervous control really, and primarily it depends from on the vascular resistance. That's on the systemic side, systemic vascular resistance. Primary side is a pulmonary vascular resistance. And again, once you can assess that vascular resistance, that can be modified very easily with the vasoactive medications, or even non-pharmacological therapies, as you mentioned here. So next, we go to the assessment and monitoring of the hemodynamic instability. At the moment in your ICU and my ICU, unless you got something special, these are the common parameters what we use. We examine the baby's capillary fill time, pulses, blood pressure, continuous, invasive, non-invasive, heart rate, oxygen saturations, urine output, weight, serum lactate. Why we use them? First thing, they're easily available. They're on bedside, they're continuous, they can get trained. Nurses can do it for you. It doesn't take time. But sadly, they are all indirect and proxy parameters of the cardiovascular well-being. None of them tell about the real cardiovascular physiology there. If you work in the CICU or pediatric intensive care, and then you can do continuous central venous pressure, mixed oxygen saturations, maybe a NIRS and perfusion index, non-invasive cardiac output, and some of these we can do in the NICU setting as well. But again, sadly, they are not available in the emergency situations. A baby suddenly collapses in front of you or has got a cardiovascular compromise, may not be there, and some of them, they are not easily done in the preterm babies. Bedside point of care ultrasound or functional echocardiography or targeted echocardiography, what you call it, is different name really. So they can provide not only anatomical, but the physiological parameters to assess the cardiovascular physiology far better than all these parameters. What about the endpoints? At the moment, we tell our colleagues and our team that these are what we are looking for. I want to see the perfusion index getting better. Urine output should get better, 0.5 or at 1 mL per kg per hour. And lactate should start coming down, pulse is getting better. All these markers, again, they are very useful, they are very clinical parameters, and they are well established. They all have been extrapolated from the adults' practice to the children's, from children's to the neonates, and from the term neonates to the preterms, but without any strong evidence for the preterm babies. But they are reasonable, they are sensible. I think in absence of any other robust endpoints, I think they may be sensible. But in my opinion, now we have got the tools and we have got the technology, we can modify them. We definitely can use far better therapeutic endpoints. Using the functional echocardiography, using the NIRS, we can combine. If it's given my choice, again, I'm not saying that I use in my day-to-day practice. NIRS is, again, we do in the research tool, but we are not using in our clinical practice. I would like to use more. Definitely, if I got a functional echo I use day in and out for these patients with a cardiovascular compromise, if I can combine functional echo and NIRS, that will tell me about the cardiac output, about the blood flow in the major vessels, and also NIRS will tell me about has this been delivered to the tissues. Clinical parameters, they are very useful. They give continuous trend as well, and so the laboratory parameter. So I think you combine 3 of them, I think that's a very good monitoring, hemodynamic monitoring. As I said, once we know where the problem lies, management is not difficult. Management is the easy part. And I always say in my rounds, if you normalize the physiology, it's all physiology based really. If you normalize the physiology, your patient is going to get better. And that's why how we should choose the inotropes, to normalize the physiology rather than normalizing a number or working on a number. If you get the decreased preload, you can give the fluid therapy, you can give the, if it's a low HB, you can give blood, it's very easy. Increased preload, you can diuretic therapy. Again, diuretics are vasoactive drugs. They are not inotropes, but they are equally important. If you decrease preload, we can vasopressor therapy, and I'll go in details in coming slides. Increase afterload, like in the pulmonary hypertension, in that case we can give pulmonary vasodilators. And similarly, if we can decrease myocardial function, we can give chronotropic or lucitropic drugs, make the myocardium better. And same, we can increase the oxygen carrying capacity by keeping the HB on the good side and also treating the acidosis, all those parameters. These are basic principles. But when you look on the tiny bit nuts and bolts of these drugs, they are quite complex and the mechanism of action is quite complex. But the good thing is they're absolutely well studied in vivo in the animal studies, and pharmaceutical companies have done enough work to bring them in the market, and we all understand their mechanism of action pretty well. If you divide these drugs into different categories, they can be one like say vasopressor therapy, they're vasodilators and chronotropics, they're much easier to understand. But let's simplify for the purpose of the talk, otherwise we will be on this slide for a long time really. So this is very simplified approach, not the 100% what from the previous slide. If you look at the dopamine, definitely it increase the blood pressure, may not improve the blood flow, what we said, increase your systemic pulmonary vascular assistance and also cause tachycardia. Epinephrine improve the cardiac functions, especially on the low dose, increase your vascular assistance, especially on the high dose. And both of these drugs have dose-dependent effects, which we'll discuss in the next slide. Norepinephrine is more of a vasoconstrictive and less inotropic, and has increased the systemic vascular assistance far more. Vasopressin, telpressin, they're the potent pure vasoconstrictors without an inotropic effect at all. And if your child has absolute septic shock, warm shock, and you need pure vasoconstriction, cardiac functions are good, in that case that's your friend. But I say cardiac functions because that you need to know first. Then comes your hydrocortisone, which is again is a steroid, but it works by the catecholamines, by increasing the catecholamines in the blood and also increasing the sensitivity. Then comes to the D-vitamin or vasodilator therapy. Again, there are 3 commonly used. D-vitamin you guys use more than anything else, but again it has a chronotropic effect and inotropic effect. Both increase the blood flow and also the cardiac function as well. It's not a bad drug. Actually it's a pretty good inotrope. But even better can be milrinone, especially certain conditions like the PPH and pulmonary hypertension, which not only is a better inotrope, is a lucitropic, increase your cardiac functions without increasing the oxygen demand, but also decrease the pulmonary vascular assistance. So it's an ideal drug if you combine with epinephrine. And there's some more data is coming in the levosimendan, again more like milrinone really. And then we are not going to talk about the pulmonary vasodilators in today's talk, but they are also vasodilators, but on the pulmonary circulation on that side really. So dose dependent response, again there's a medical student question really, but you all know still. Let me summarize this one for the before we go ahead. If you look at the very tiny dose, 2 to 4 microgram per kg per minute is primarily dopaminergic effects, what we use for the renal or mesenteric, those will increase the circulation to the gut and to the kidneys. If you look on the modest dose, which is 5 to 10 microgram, it's a pretty good drug in terms of the inotropy. But problem is people keep on increasing the dose high and high, especially up to 8 is pretty good drug, works by the beta 1, beta 2, some effect on the alpha 1 and its receptors, slight increase the vascular assistance, but better chronotropic effect is not bad. But when you increase the dose to 10 to 20, that's where I start worrying, and that's why often I find my patients on these very high dose, because at that point your effects on the beta 1, beta 2 almost diminished, and mostly primarily on the alpha 1 receptors, where numbers is great, it's absolutely fantastic, but your blood flow is absolutely poor, including the pulmonary blood flow. Or more importantly, especially used in the conditions we are treating the pulmonary hypertension or high vascular resistance, you are increasing the pulmonary vascular resistance, you are just counterproductive really there. Similarly, epinephrine is a low dose, fantastic drug, absolutely great drug, because it not only increases your inotropes, your heart contractility, but also slight modest increase in the systemic vascular resistance. So it increases your numbers as well your cardiac contractility, both really. But again, high dose, be mindful, if you use more than 0.4, it will definitely lead to more vasoconstrictive effect, and there may be some increase in the pulmonary vascular resistance, but that evidence is poor. As I said, you need to know your goals of what you want to achieve when you're choosing the inotrope, and that goal should be based on the underlying pathophysiology, underlying which part of which physiology altered. Is the vascular resistance, or decreased blood flow, or cardiac function, or you want to reverse the shunting like the PPH, and you want to shunt, change from left to right to left, change to left to right, increase the systemic vascular resistance. It depends on your goal really, and you can target the same with the medications. And lastly, I put on the improve echocardiography findings or biochemical or abnormality markers. This is important as well, but we should not treat the numbers, should not treat the imaging, we should treat the patients. There are certain special considerations. Neonates are definitely they are a unique pathophysiology, especially in the first few days. In the first few days, the most dramatic hemodynamic changes ever occur in our whole life. If you think you're doing bungee jumping from 10,000 feet, if you think they'll affect us, that's nothing as compared to what hemodynamic changes occur in the first 48 hours really. Your vascular resistance drops almost tenfold within a few seconds, and keep on dropping up to like 15 to 20 times in the first few weeks. Similarly, your diastolic dysfunction in the preterm neonates, that start working against the vascular resistance, which is increased, and that takes again adaptation of the myocardium within the first 48 to 72 hours. So we had to take into account when choose the right inotrope for these babies, especially the preterms, where the survival is getting better and better. And this more and more data is coming. If we do not act them early, and there are studies from 2016-17 the adults, preterms babies who are survived, and they will have the high risk of the cardiovascular complications, including the heart failure in the early adulthood, and that in the coming decade or so that data will be much robust. Definitely few studies have been published there. So when you choose, definitely keep in mind about the inherent dysfunction of the very preterm infants, and also the hemodynamic impact of the large PDA. I'm not a strong believer of treating the PDA, but I'm a strong believer in assessing the hemodynamic assessment, so that we know when we should act on our hemodynamic derangements. Sometimes people will be treating the baby with the inotropes, like say mean blood pressure is low, but look at the diastolic is very in the boots really, thus pulling the mean blood pressure low. Systemic is good, that baby may have a very large PDA. So just be mindful, look at the whole picture rather than just the mean blood pressure there. And then about the effects on the disease pathophysiology. Preterm infants, especially even the term infants, they do not tolerate increased vascular resistance as like the older children or like the adults, and their physiology altered much faster than the older children. And lastly, half-life. Again, knowing the drugs is really important. Like say I was talking about milrinone, I like this drug, it's a fantastic drug for the pulmonary hypertension. But thing is, somebody will ask me, oh, shall we always use? No, we need to understand the pathophysiology. If child has got a HIE and is therapeutically cooled, in that case, if the renal dysfunction is there, milrinone will accumulate in the body, and you have to use short term, 48 to 72 hours, get out of there. So you need to understand when to use, how to use, and how long for. So that's normally where we start considering the inotropes, where you got the poor hypertension or poor cardiac output or cardiovascular compromise. It can be because of the different underlying pathophysiology, from the decreased afterload, like in the classically in shock, in the sepsis, can have poor cardiac functions, can be a long-standing effect of the infection or cardiovascular compromise, or secondary to the persistent high vascular resistance. Increased afterload, increased your LV preload, like in the PDA, with, or in the systemic side leading to the heart failure. Point of care echocardiography can help in differentiating these 4 important underlying pathophysiologies on the bedside. And it can help in targeting the intervention based on the deranged or altered pathophysiology rather than guessing a number. If you are dealing with the decreased systemic vascular resistance, like in the shock, you can give norepinephrine, or PIC will use more vasopressin or telpressin. So you can go for those drugs. I will prefer in the shock more of a norepinephrine there. If with poor cardiac functions, in that case you can use epinephrine early on, or you can use low dose of dopamine if you really want to use dopamine but not the high dose. If you've got an increased afterload, you can definitely, there are drugs are out there, we can selectively decrease the vascular resistance based on the pulmonary systemic side, you can target therapy. And same in the heart failure or the volume overloading the left side, you can target your management based on the which side is involved. And then it can also help in identifying the specific causes. Sometimes things unexpectedly do happen. So they can be underlying heart defects as well, not very common, but they may have underlying coarctation, underlying certain conditions, you may treat them. Or sometimes heart is failing, like the bad pulmonary hypertension, this RV is failing, and this baby may need prostaglandins rather than your conventional inotropes. So it can help you, it's your friend. I'll take a couple of, and there are a couple of videos are there. I think I've got some time really. So this is apical 4-chamber, and people who don't do echocardiography, this is the where my probe is. This is the left ventricle, that's the right ventricle, that's the left atrium, that's the right atrium. And if you can just, you don't need an expert to say, in this case, right ventricle looks more thickened and the hypertrophied, left side looks small. This heart looks underfilled, and possibly is a pulmonary hypertension there in this side, in this baby. As compared to this side, left ventricle and left atrium, they are quite dilated, and there is a volume overloading. Normally, you would expect either both ventricles same size or LV slightly more dominant than the right side. So this is volume overloading. This baby may need a fluid bolus, or you're correcting something there, or as compared to this child, it will not benefit from the fluid bolus, and in that case you may choose to restrict or may give some specific medications to offload the heart from the volume overloading. Now these all are real cases, and every single case I can talk for 5 minutes really, but we are focused on inotropes rather than the whole case, but this is a really interesting case. Look, this baby is a baby who was born in poor condition at 36 weeks and needed CPR, and was intubated, ventilated, and mean blood pressure was 17 or 18. pH was 6.9 with a very high base excess -21, unrecordable lactate. What you'll do? Most people give the fluid bolus, and that's what the team did. As soon as you give the fluid bolus, this baby collapsed completely, had a second arrest needing longer CPR. They stopped the fluid bolus and they revived the baby, put the child again. Nurses started to give, baby thought they may be septic, and nurses in that case started to give the antibiotics. Just a couple of mils fluid, with the bolus, just with the bolus, baby had another collapse. There's a third CPR. But the team did a great job, revived the baby again, baby came back, and then they discussed with us, what shall we do? We studied inotropes, brought the baby on our side from the small center to our side, and this is what we find when we put the probe. And this is after studying inotropes. I'm sure this would have been even more rubbish before, soon after birth. Sorry, that's the only word I can use for these cardiac functions. So this is absolutely, this has a dreadful cardiac functions, contractility is very, very poor. And this is the same baby after 4 or 5 days. Now question is, if you are a friend of dopamine, and use the dopamine, and that's what the team used there, that's what they used rather than epinephrine or anything else. We said start dopamine, but as we discussed, dopamine does not increase your numbers, increase your blood flow, what we want, but you don't want to leave your blood pressure 17 in 36 weeks either. So they used initially dopamine and they used dopamine very soon, and baby came to us both in 2020. But if you use the dopamine of 20, what will happen? You'll increase your systemic vascular assistance. But on the other hand, what's happening? This baby is born in a poor condition. Rightly, this baby is cooled as well. Cooling is great for the brain, and what David will talk in his talk, but it increases your systemic vascular assistance. And you got these dreadful functions is not going to cope with such an increased systemic vascular assistance, and that's why where role of the underlying pathophysiology comes really. If you use this baby on the inotrope and stabilize more with the epinephrine, give some time and increase the epinephrine, and maybe once your blood pressure gets better, then add milrinone, not in the beginning, or you add the epinephrine dovitamin, the blood pressure number is not better, you may achieve far better results. And this baby had cardiac function so poor, not many in like last 6 years we have stopped cooling for any of the babies, but in this baby we had to stop cooling, baby is dying otherwise. So, but if you choose the right inotropes, you can make big difference, and once you choose the right inotropes, this is the results out there. So you can make big difference underlying the pathophysiology. Now, next two cases are both are the severe pulmonary hypertension. Both have got the state-of-art management for the pulmonary hypertension, including oscillation, nitric oxide, multiple inotropes, everything, whatever you name it. I'm not going to PPHN management. But this baby, as seen the image where I was called in to help out before, or shall we put on the ECMO, or refer for ECMO, or can we do something else? This baby had a couple of boluses of fluid bolus by the transport team and by smaller hospital, was on multiple inotropes. Multiple means 5 inotropes to maintain a systemic blood pressure of 55 to 60, because where the shunt is left to right side and there is a less pre and post rectal sets difference. There is a hypertrophy there, and you can see the kissing sign of the left ventricle, you can see drop out there. This baby is completely is a underfilled heart, hypovolemia. And I looked into the more detail, like in the cardiac output, and left and right side cardiac outputs as a very low cardiac output state. That's why this baby's got very decreased pulmonary blood flow. And this baby, essentially, we gave the fluid bolus, and we could wean off inotropes within few hours, within 6 hours, from 5 to 2 inotropes. Within 48 hours, this baby was extubated, and we never put an ECMO. As compared to this baby, again, the similar kind of baby, both had absolute severe hypertension. This baby in the further down in the line with the pulmonary hypertension, this baby is has got a very dilated right side of the heart, right ventricle, not only hypertrophied, you can see the hypertrophy, dilated, big right atrium, all structural normal heart. I have not put any heart defects there, all are normal hearts, promise. No TAPUD here. So this baby is right ventricle is completely failing. If you give the same fluid bolus to this baby without knowing, you will kill this baby. This will collapse on you, because this baby is absolutely failing heart. This baby needs offloading the heart with the different medications. Although clinical picture looks same, both have got PPHN, both have got the pre and post rectal sets difference. The inotropes, choice of the inotropes should be, and in my opinion, they should be completely different. Management should be different. Last one is a very interesting baby. This baby had a echocardiography done by neonatologist within 48 hours, 24 hours really, had a PDA, PFO, structural normal heart, had a very bad chorioamnionitis, PPROM kind of picture, but there was no clinical pulmonary hypertension, and this baby managed as normal RDS, multiple surfactant doses, did very well. But oxygen requirement will come down only for 4 hours after the surfactant. It will shoot up again. So after 48 hours, people said no more point giving a surfactant. Down the line, baby became sepsis as well, and had a high CRP. On day 4 or 5, baby had a high oxygen requirement, tried everything. So blood pressure was okay, and team said, okay, let's start some nitric oxide. In that case, maybe maybe in intrapulmonary shunting, or maybe this baby the pulmonary hypertension. And within a couple of hours, this baby even more worse, and collapsed, oxygen requirement shot up. Reason for that one, when I looked in the baby, there's a very dilated pulmonary veins, baby has got a very large PDA. Nitric oxide in that case dropped the pulmonary vascular assistance further because of the large PDA, and your shunt further increased. Really, we made this baby worse. Although had a previous echo done, previous echo doesn't mean that things will not change. Physiology changes with time, hemodynamics will change with time. By day 4 or 5, your vascular assistance changes completely and your clinical picture is different. Same point, the point here, I'm not talking the nitric oxide here, point is milrinone here as well. If you use the milrinone in a hypertensive baby in the first 24 hours or 48 hours in a preterm baby, that's why people say, oh, it's a diastolic dysfunction there, let's try the milrinone, but their pulmonary vascular is dropping. In that case, milrinone is a vasodilator, will make this baby worse. So like in this baby, give milrinone, it will make it worse like nitric oxide. So again, knowing what the action is or the physiology is really, really important. So just to summarize, the point of care echocardiography is, if you talk to like, I sit on both sides in the peds cardiology and neonatology, I'm a hybrid, so I do cover PICU. For the PICU, things are much easier, guys. I can say point of care ultrasound, and with the ESPNIC, we are coming up with our point of care ultrasound guidelines. For me, it's much easier to say, if you've got a baby who's more than 2 weeks, especially more than 4 weeks old, point of care ultrasound, I can train my trainees within few hours or within maximum couple of days, and they can do a point of care ultrasound 5 things. 5 things is the heart empty or overfilled? Has baby got any cardiac tamponade or not? How is the contractility, is good or poor? Shall I get inotropes or fluid? That's the whole question in the emergency setting, PIC setting is the baby pulmonary hypertensive? What shall I do with this patient? But it comes to neonates, things get complicated because we deal with the undiagnosed critical congenital heart defects. How good we will be on the fetal echocardiography, we cannot diagnose 100%. Some certain conditions like say coarctation or the left side heart problems or TAPVD, they're notorious and we cannot diagnose 100% how good we will be. So that's why for the neonatologist, for you and me, when as a neonatologist, things get more complicated, we need more extensive training. And as you all know, we have been, that's absolutely my passion, and where I want to see not all, but most of the neonatologists doing echocardiography in maybe 10 years, 5 years, 20, I don't know, in my lifetime. So and we have been working very hard to push it forward. And we had, definitely in the last 10 years, there have been at least 3 important guidelines that come. And things have changed. The things are changing both. In Europe, we are pretty good actually. but in the US, now things are far better and people are doing more and more. So we published a guideline in 2015-16. Initially, TNE came from the North American, then UK, and then European. And we are trying to push more on the certification and accreditation for those guidelines to help so that you guys can use this bedside ultrasound or bedside echocardiography so that to understand the pathophysiology and try to make things easier for everyone to develop this training. But it's not about training, as I said, you heard a lot, you must have been bored by now about the physiology word, but honestly that's what I like, that's why I absolutely strongly believe in it, because you understand the physiology, cardiovascular physiology, your patient, you can make the big difference. And that's why rather than just talking the echocardiography, we should be talking the hemodynamic assessment, hemodynamic evaluation. And from all the 3 guidelines, we joined hands, both from the Australian and from Toronto group and North American, and we it has come a few days back, our more toward the hemodynamic consultation, where we're talking, say, if my juniors calls me, can you do an echo? It doesn't mean anything to me, guys. Echo is a imaging technique. If I don't know what your question is, why you want an echocardiography done, what your question for the hemodynamics is, I have absolutely no clue. I can do an echo which may not make any sense. You need to tell me, do you want a structural echo or a functional echo, what you're struggling with. Are you struggling with your blood pressure? Are you struggling with the tissue perfusion? I can do the assessment far more details with the advanced functional echocardiography. That's why our move towards the hemodynamic consultation in the coming years. Maybe I talked a lot. Maybe a question for you guys. Let's do a couple more questions, Francesco. So in your opinion, can echocardiography help in making a physiology-based choice of inotrope? I try to convince you guys, still I may not convince, who knows? There are always skepticals are there, and they like those because they push us to think things do better. Because when I started these NP guidelines, my cardiologist colleague, the simple word they use, we don't need to train neonatologists, they'll kill their babies. And I said, they're already killing, they're already doing it. We need to put a proper structure in place, we can train them properly. Still, I told you that 3%, I like those 3% because they really push me even further to make those things better. But thank you for 97% as well. How many of you use, can we do the next question, please? How many of you use functional echocardiography routinely for the hemodynamic evaluation in the sick patients? I'm not talking about the all patient. I'm not talking about a simple bit of low number. When you think, oh, this poor perfusion is there, hemodynamics is deranged, let me look at the hemodynamics rather than just the normal parameters. Perfect. I'm really pleased to see, honestly, had I this asked question like a few years back, not only reverse, it would have been 10% or 15%. And thank you very much for who are already starting to use echocardiography. I think it's all about the patients. It's all about making them better to be in time, timely diagnosis, timely management. And the echo does help, at least I believe. Let's do the next question. This is, how many of you would like to develop skills in the echocardiography, especially the functional echocardiography for the hemodynamic evaluation of the sick patients? And there are two kinds of echocardiography you can talk. One is structural, one functional. Functional one can be very point of care ultrasound, few seconds putting the probe really. And with the advanced functional, you can do the cardiac outputs, you can do your tissue Doppler imaging, you can do far more spectral tracking. You can do a lot with them and you can specifically answer those questions. But again, this talk is not about the echocardiography, so I'm shying away from there. We've got a workshop and towards the end of the day, end of the conference, we'll talk a little bit more on the functional on that day. Again, fantastic, 94%, and I do have respect for 6%. We all do not need interest in every single subspecialty. I may understand less endocrinology, which is fine because we don't need all, but 93% is fantastic, that's great. All right, let's try to summarize my talk. So that's a suggestion. I'm not saying that's my opinion and that's, there is no strong evidence for that one, but that's a logical suggestion really based on the physiology. If I have to choose inotropes with the preterm baby in the first 48 hours, I'll go for the dopamine. Reason is simple, it's logical because they have the diastolic dysfunction. They got a low cardiac output state. We can increase the cardiac output in them when they got the hypervascular resistance, and those babies in myocardium will be better respond to the dopamine rather than the dopamine. But after 48 to 72 hours, where the myocardium has adapted to the change in the vascular resistance, in that case, dopamine is not a bad drug, but in the low dose, up to 5 to 10, I will try to shy away more than 10 until as I have to. Septic shock, norepinephrine will be my choice. Again, vasopressin, telpressin, they have got less experience. They are pretty potent toxic drugs. You need a proper central line. I think norepinephrine is far better drug, and I'll definitely go for the norepinephrine as the first choice. And if you've got cardiac dysfunction in addition to the shock, I may go for the epinephrine in that case, or a combination of both on the low dose even can be better really. Pulmonary hypertension, again, we get a lot of patients coming from the district general hospital who are often dopamine. Again, not a bad drug up to 10, but more than 10, definitely shy away. If you say my choice, personally, I'll go for the epinephrine first, and low dose epinephrine somewhere about from 0.05 to 0.4. And once the blood pressure is better, if your systemic blood pressure is more than, I'm not picking a number, but which is in more normalish range. Once your stable blood pressure I will talk about rather than the number, I can add milrinone. Again, please do not give the loading dose what adults, what our PICS people do, or adult cardiology or PICS cardiologists will recommend. Babies do not tolerate the loading dose better, so start with a dose of 0.25 milrinone, and it may take 1 or 2 hours. It's a fantastic drug, but you may have to wait for 1 or 2 hours for the effect if you use the loading dose. HIE, again, dopamine may be better drug. Again, the same thing. It does cause the cardiovascular compromise of the multi-organ dysfunction in the HIE with the perinatal asphyxia. Again, the same pathophysiology like the preterm babies. And again, they do have the high systemic vascular resistance, and it will increase the blood flow to the brain and to the lungs. I think maybe better drug. Again, personally, I use the low dose of dopamine with a low dose of epinephrine. That's far better, best of both worlds if I had to choose one of the drugs if I'm managing these babies. So summary and take-home messages. There are many vasoactive drugs, and as Francesco Stefan said, there are many drugs and there are many to choose, and rightly as well, and they're well studied. We know how do they work. We know how they interact with each other, and we can use them carefully after careful consideration of the underlying pathophysiology. I do not have any evidence, and people ask evidence. It's great to be researcher. Absolutely, we should do more research, and hopefully we'll reach one day. But this is one of the most difficult area to research in the neonatology. And if you talk to Eugene Dempsey, who initially thought of the trial placebo versus dopamine, took 3 years for the trial to just take off, and that's only dopamine, which I say is a horrible drug, is a poison, that we will spend more than 3 million euro on that one. So it is a very difficult area of research, but understanding the physiology, training the echocardiography, much cheaper, much nicer area to do really. A physiology-based approach likely to be helpful, in my opinion, that would be likely to be helpful in providing individualized precision management to the baby, depends on the specific condition. Bedside echocardiography can provide physiological information which can make your clinical decision based on the pathophysiology. Again, you have to be clinical knowledge. You have to pull the whole picture, not the echo imaging. That's the hemodynamic consultation we are talking about. You should be looking at the whole picture, and echo imaging just a tiny adjunct part of the bigger picture. And lastly, again, based on these one, you can do different guidelines, and that's basically, if I give my choice in my practice, I do these kind really. We can divide into different categories, what I said really, and like preterms, dopamine. Rather than saying one drug, then you can different when should the echocardiography should be performed, what can be a second line drug can be. Again, in the PPHN, I still put the dopamine, but up to 10. Reason for that one, still, as you said, 80% of you guys use dopamine, and I do get referrals from at least 17 hospitals, and including I work with the 13 colleagues who like dopamine as well. So, but I will prefer not to go more than dose of 10. Which are in bold, there will be my choice as a first drug, like in this case, dopamine, the preterms, same with the HI, dopamine. With a term baby or preterm baby after 48 to 72 hours, I'll follow this pathway. I think you guys can see it, but I can make it slightly bigger if that makes it a bit easier. And then you need to have your pathway, rather than going on a very, very high dose. Sometimes one drug is not affecting because they work on the different receptors, and sometimes your effect is unpredictable. So I need water, and I guess now. So, so I think when you get the very high dose of one drug, I'm fine, Francesca, I'll get it now. So a very high dose of one drug, in that case, it may be better use combination of therapy. That's why, as a cardiologist, we use in CICU rather than going on one drug on the very high dose. Thank you much. Get the more adverse effects. Better use a combination of therapy, get the best of the world without the adverse effects, if that makes sense. Nearly done, guys. So then you need to have your pathway, again, when to ask for help, when to ask for the echocardiography, and when to ask more help. And the lastly is really important to know about what other causes can be their pathophysiology based. It can be an underlying pneumothorax which is undiagnosed, can be your equipment problem, technical problem. And I can tell you one interesting case where one baby who has a hypertension, people focusing on number, gone the dopamine 20, dovitamin 20, hydrocortisone, and getting on the epinephrine. And I said, doesn't make any sense. The baby should not be that hypertensive. Your cardiac function are good, everything is good. And I said, have you checked zeroing the system, everything? People, yeah, we've done everything. Can I say, I'm really being paranoid here. Can we re-zero in front of me, please, again? Nurses were a bit upset, but they did. And blood pressure was actually hypertensive. We had to wean down inotropes. The very basic things, really. If things are not responding, babies should respond to these medications. They do not respond. Either you're choosing the wrong drug or something else wrong can be there. And the lastly is about the PHN, so about the pulmonary hypertension. Again, you need to have, different thinking really. You need to have your own guideline, own pathway. This is what what I personally use. Again, these babies, when we fluid bolus, again, dopamine is not, as I said, not a bad drug, but I'll prefer to go into the second one with adrenaline. Again, put the dose, not very high dose because they'll be vasoconstrictive, modest dose of epinephrine, norepinephrine or hydrocortisone, but early echocardiography, early understanding the functions, that can be very helpful. I'll stop it there and I'm happy to take any questions.